Hello, everyone. Thank you for being here today. We are going to get started here. My name is Jamie Seward. I'm the Associate Director of Affinity Engagement Programs with the Office of Alumni Relations. Now, before we proceed, I'd like to acknowledge our co-sponsors, the Department of Neurology and Brain Sciences and the Healthcare Affinity. Now, before I turn the program over to our moderator, I encourage you to ask questions by typing them in the Zoom Q&A in the bottom of your screen. Now, I have the pleasure of turning the program over to our moderator, Rachel Ermer, Assistant Director of Development for the Department of Neurology and Brain Sciences. Rachel, take it away.
Thank you, Jamie, and thank you to all of our attendees this afternoon. First, today we'll hear from Dr. Michael Kornberg. Dr. Kornberg is an Assistant Professor of Neurology in the Neuroimmunology Division and an Associate Director of the Neurology Residence Program. He specializes in the care of individuals with multiple sclerosis and other autoimmune diseases of the nervous system. He will be discussing his research focusing on identifying targets and developing treatments for multiple sclerosis with implications for other autoimmune and neurodegenerative diseases.
All right, let me get my screen up. All right, and I will get started. Thank you, Rachel. And I want to start by saying thank you to everyone who's in attendance. I know we all very much appreciate your interest and we're all excited to talk about our work. So as Rachel mentioned, my particular clinical interest is multiple sclerosis or MS. And I do primarily laboratory-based research focused on understanding MS and most importantly, developing therapies for people suffering from MS. And I hope that this work also has some implications in both neurologic and non-neurologic diseases beyond multiple sclerosis. But to get started, because I know we have a diverse audience, I just wanted to give a little bit of background about MS. So in its simplest description, MS is an autoimmune disease in which the target is something called myelin. So our immune systems, as you may know, are designed to fight off infection, but in autoimmune diseases, the immune system becomes overactivated. It misfires and recognizes part of the body as the enemy. And in the case of multiple sclerosis, the target of that immune attack is something called myelin, which is the insulation around nerve cells that helps them to conduct their signals. And so when these nerve cells are missing their myelin coating, they don't transmit signals as well. And this produces a wide spectrum of both physical and cognitive disability. And in this respect, MS has a lot of overlap with other autoimmune conditions, even ones that don't affect the brain, like lupus, rheumatoid arthritis, Sjogren's disease. But obviously this is affecting the brain. And in addition to the loss of myelin, both at the beginning of the disease, but even more prominently later in the disease, we see a significant component of neurodegeneration, where rather than simply nerve cells missing myelin, the nerve cells themselves start to degenerate. And this has a lot of overlap to the pathology we see in classic neurodegenerative diseases like Alzheimer's and Parkinson's disease. And this is a schematic overview of the natural history of multiple sclerosis for a typical patient. So a typical patient will start off in what we call the relapsing remitting phase over here, which is characterized by these discrete episodes of inflammation in which the immune system attacks a new area in the brain or the spinal cord and produces neurologic symptoms. As that inflammation subsides, there is some recovery, those symptoms improve, sometimes all the way back to normal, but unfortunately in many cases, people don't recover all the way to normal and are left with some irreversible disability. And each of these attacks is called a relapse, and hence relapsing remitting MS. Later on in the course of disease, many people will enter what's called the progressive phase, which is characterized by this insidious progression of disability that happens even in the absence of any superimposed relapses. And through a combination of what's called progression, and failure to recover from prior attacks or repair that myelin damage, people develop disability over time. And these two stages of MS are characterized by inflammation on the one hand. So the relapsing remitting phase is really all about the immune system getting revved up and angry in the lymph nodes and invading the brain to cause damage, and neurodegeneration in the progressive phase of the disease. We've had some success in preventing relapses, much less in slowing progression or promoting repair. But really, we need treatments that target both of these processes. And the work that we do in my lab focuses on elements of both of these parts of the disease. And I'm going to talk to you about two particular lines of work, one that's targeted at the immune system and one that is targeted at progression. So one of the main areas of interest in my lab is understanding the connections between diet, metabolism, and inflammation. So how do the foods that we eat and the way we metabolize those foods change the way that our immune system behaves? And if you ask the internet or if you ask Dr. Google, there's some clear connections here. I'm asked about diet probably 2 or 3 times a week by my patients. And as someone who studies diet and inflammation and feels strongly that there's a connection there, I can also tell you that the things that we see on the internet when one diet is called pro-inflammatory and another is called anti-inflammatory, it goes about 100 miles beyond what we actually know. The truth is that we don't know any specific diet that is good for the immune system or bad for the immune system. But we have a lot of reason to think that there may be particular diets that have specific effects. And a big part of that is work that's been done in immunology over the last 15 to 20 years. So, one of the more exciting findings in immunology over that period of time is that when immune cells become activated, so when they receive these inflammatory cues that push them towards becoming pro-inflammatory, kind of angry cells, they change the way they make and use energy. And specifically, they become very dependent on using sugar or specifically glucose for their energy needs. They upregulate this process called glycolysis, which is how we break down glucose for for energy. On the other hand, when these cells receive anti-inflammatory cues, basically signals that are designed to kind of tamp down the immune response, they take on a different metabolism that is much more dependent on fatty acids and lipids going through something called oxidative phosphorylation. And it's been shown very well in animal models, in cells that are in culture, that if you can prevent cells from utilizing sugars and force them towards this fatty acid type metabolism, you can kind of also force them away from this inflammatory function towards having anti-inflammatory or regulatory functions. But what had been missing during this period of time was any proof of concept that these metabolic pathways could really be targeted in human beings to modulate their immune response and to treat disease. And so that leads me to the first part of the work that we've been doing and how I became interested in this topic to begin with. So I started studying metabolism and the immune system several years ago when I was trying to understand how one of our MS drugs work. So this is dimethyl fumarate. It goes under the trade name Tecfidera, and it's a drug that was approved for use in multiple sclerosis in 2013. But it was developed essentially by dumb luck. We knew that it worked, but we really had no idea why it worked. And I became very interested in understanding the mode of action of this drug. And the reason for that, and the reason I was so fascinated to begin with, is because dimethyl fumarate looks very much like something called fumarate, which is part of the Krebs cycle. And for those of you who were either lucky or maybe unlucky enough to have taken biochemistry at some point, you may remember that the Krebs cycle is a series of chemical reactions that happens in just about every cell of our body. And one of the elements of the Krebs cycle called fumarate, if you just slap 2 little methyl groups on the end of fumarate, you have dimethyl fumarate. And so the question is, why does this glorified metabolite we have in all the cells of our body, why does it have an effect on the immune system? And what we found and what we were very excited about was that it turns out that dimethyl fumarate specifically blocks cells from upregulating their metabolism of glucose. It basically prevents active immune cells from using glucose or sugar for energy. And this mediates its anti-inflammatory effects in the body. And we think that this is just an exploitation of a natural function of fumarate. So the Krebs cycle happens just downstream of how we metabolize glucose. And so we think that this is a natural kind of feedback mechanism. And dimethyl fumarate is just a more effective form of fumarate at having this effect on sugar metabolism. And so what was very exciting to us about this work is that it was the first proof of concept that there is a drug that targets a simple metabolic process in people, but has significant effects on the immune system, and in fact is a treatment for multiple sclerosis. And we had published this work in Science a couple years ago. And so we're going forward with this work in a number of ways, basically trying to understand the ways in which metabolism impacts the immune system. But one of the major things we're doing right now that I wanted to highlight is looking at the effects of diet on the immune system, and specifically the ketogenic diet. So some of you may be familiar with the ketogenic diet. It's a diet that's very low in carbohydrates and sugars, also low in proteins, primarily dependent on fats. And essentially it deprives the body of sugar, of glucose. And based on what we saw with dimethyl fumarate, having anti-inflammatory effects by inhibiting the metabolism of sugar, we are hypothesizing that the ketogenic diet will similarly have anti-inflammatory effects. And we're collaborating with other people within the neurology department, specifically within the epilepsy division, to study the effects of this diet on human immunity, which will be, we think, the first really rigorous study of a particular diet on the human immune response. And so with that, I'm going to shift gears quickly and talk about the other line of work in our lab, which is really focused on understanding how we could slow or halt progression, and how we can promote the repair of damage that's been done so that we not only prevent further injury, but we actually promote recovery of function. And in order to do this, you have to understand first, of course, what the biology is of these processes. And there's a lot of evidence that the immune system continues to play a role in progressive disease. It's just that that role is different than in the earlier stages of disease. And in particular, what we know about progressive MS is that whereas in relapsing MS, the immune system is getting activated in the blood and the lymph nodes and invading the brain, in progressive MS, we have this persistent activation of immune cells within the brain itself. And it's a different type of immune cells. It's what we call the innate immune system. And these are cells like astrocytes, macrophages, microglia. In MS, they continue to be active at the edges of lesions and also diffusely throughout the brain. We know that they correlate with worse prognosis in people. We know in animals that they lead to neurodegeneration and they prevent myelin repair. But we have no current therapies that target these cells within the brain. And so this is kind of a major therapeutic opportunity from our perspective. And the way we envision tackling progressive MS and myelin repair, which has been a very untractable problem to this point. And besides just turning these cells on or off, macrophages, microglia can be both good or bad. So they can have some functions that are disease associated. They're pro-inflammatory. They kind of propagate inflammation. They release toxic molecules that damage nerve cells and other parts of the brain and just generally contribute to tissue injury. On the other hand, these cells can specifically promote regeneration by clearing debris, by secreting regenerative factors, and by specifically promoting the repair of that myelin coating. So what we really need are treatments that push these cells from disease-associated functions to regenerative functions. And in this regard, we've become very interested in a drug called bryostatin 1, which targets a protein called protein kinase C. And one of the things that we are most excited about is that bryostatin 1 has been tested in people for other conditions. Specifically, it's been tested in cancer. And unfortunately, it didn't work in cancer. It's not really a chemotherapeutic drug, but it was taken through phase 2 trials. people were treated for up to 2 years, and we know that it's extremely safe. And so that threshold for testing it in people with MS is very low. And what we found through our animal studies is that bryostatin 1 specifically promotes regenerative functions in these macrophages and microglia that we think are causing these problems in progressive MS, and prevents these disease-associated functions that we think are bad. And in our animal models, we've seen that this protects nerve cells from injury and promotes the repair of myelin through these myelin-repairing cells called oligodendrocyte precursor cells. And so some of this work has been published, some of it is ongoing, but what we're most excited about right now is that we're in the planning stages for doing a pilot study in MS patients. And we're very hopeful that within the next 1 to 2 years, we will be studying this on a small scale in people with MS. Again, because the safety of this drug has been so well established. And so that is a kind of very brief, high-level overview of some of the work that we're doing in my laboratory. I won't spend a lot of time with acknowledgements, but I do want to point out that science is very much a team sport at this point. Hopkins, one of the most wonderful things about it is how collaborative of an environment it is, both within the Department of Neurology and outside the Department of Neurology. And there are many people inside and outside the department that have contributed to this work. And I want to thank them and the organizations that are funding the work. And of course, our patients who are the ultimate inspiration for the work that we're doing. And so with that, I will stop and ask if there are any questions, if we're doing those now.
Thank you so much, Dr. Kornberg. We do have a few questions for you. The first question, is it known why African Americans have a higher level of autoantibodies during the relapsing remitting phase of MS?
It's a great question. We know some things on a population level about how people of different ethnic or genetic backgrounds do with MS. And I think one of the things that is kind of buried in that question is that we know that African Americans tend to have more severe forms of MS. The simplest answer is we don't know why. Anytime that we have these questions of ethnic differences in the severity of a disease, there's always the question of kind of untangling, the socioeconomic, the implicit bias, all of those things away from, any underlying biology. We suspect, because in MS we have this advantage that we can kind of take groups of people that have had essentially identical treatment, especially when you have kind of your first relapse, when you're getting people in the same stage, they've all gotten the same initial treatment, and kind of seeing how they recover from that attack. And it does seem like, controlling for all of those other things, that people of African American or just African ancestry in general tend to have more destruction of the nervous system during these attacks. Why that is, we don't know. That is obviously an extremely important topic for future research, as are all the other aspects of understanding why different groups of people have essentially a different disease.
Okay, thank you. The next question, do other MS meds act on the metabolism of glucose?
Another great question. As far as we know, they do not act directly on the metabolism of glucose. One possible exception is there's another drug called teriflunomide, which goes under the trade name Aubagio, which was shown a couple of years ago to inhibit both glucose metabolism as well as some metabolism of other energy sources that happen in a part of the cell called the mitochondria. There was good studies in animals that the effects of that drug, teriflunomide, on both of those pathways seems to contribute to its effects. Some of the other drugs probably have secondary effects. They're really, the primary effect is on the immune cell, but because of that, you see some indirect effects on metabolism. But teriflunomide and dimethyl fumarate are the only ones that have specifically been shown to have effects on glucose metabolism.
Okay. next question. Is there any role of oxidative stress in MS?
There almost certainly is a role of oxidative stress in MS. I think we have a lot left to understand about the specific roles of oxidative stress. So the conventional wisdom is that those free radicals and other other oxidative molecules contribute to the injury that happens to the myelin-forming cells and to the nerve cells themselves. So those macrophages and microglia and other immune cells that are gathering in the brain release a lot of free radicals and other sources of oxidative stress that we think cause a lot of the damage that we see in multiple sclerosis. But at this point, we haven't found a way to specifically target any of those molecules or pathways to protect the brain, which is a big area of research. It's almost certain that they're playing a role, but we have a lot to learn in terms of how we can impact those effects for the benefit of people with the disease.
The next question is, how are you feeling about stem cell therapy?
So we could probably spend the next 30 minutes, I think, talking about that one. That's a great question. So when people say stem cell therapy in MS, they're usually talking about one of two things. They're either talking about blood stem cells, or they're talking about the types of stem cells that they hope will have the ability to form new myelin-forming cells, new brain cells, and promote repair. So blood stem cells, I think, will certainly have a role, at least in very aggressive MS. The idea there is that you essentially just ablate someone's immune system by treating them with high doses of chemotherapy, and then you restore their immune system by giving them blood stem cells. And we know that that is very effective at stopping future attacks, future relapses, and may even be a form of a cure. The problem there is that there are a lot of risks associated with ablating someone's immune system. And so it has been reserved at this point for people with very aggressive disease who have not responded to other therapies. In terms of the other type of stem cell, the kind that will actually repair myelin and repair brain tissue, we are much further away there. I hope that one day, that those sorts of treatments will have a role in our armamentarium. But our understanding of the biology, of how to kind of get them in the right place and get them to form the cells that we want them to form, we are still very early on with that. And I think, unfortunately, it's going to be a while before that kind of comes into the picture.
Can you describe the keto diet more specifically in the percent of carbs and proteins, and also historically what that diet has been used for before?
Sure. So there are some varieties of the ketogenic diet. And so the exact proportions can kind of differ between those varieties, but essentially they all generally have somewhere between 70 and 90% that come from fat. Basically, kind of the minimum amount of protein you need to make proteins, but no excess of that, because any excess of that ends up getting turned into sugar, and really just minimal sugar. And the one disease that ketogenic diet has consistently been shown to have benefit for is refractory seizures, epilepsy, which is why that I'm doing that study in conjunction with the epilepsy department here. So we're very fortunate at Hopkins that it's one of the places that pioneered the use of ketogenic diet for epilepsy. And so we have an adult ketogenic diet clinic. So epilepsy patients that are enrolled in the ketogenic diet in a very standardized way, and gives us this kind of very well-controlled environment in which to look at the effects of ketogenic diet on other aspects of biology. And in my case, that's the immune system. But really the one disease that we know it works for is epilepsy.
Okay, great. And the last question, any ideas why MS attacks sites where it attacks? This seems very different from person to person.
So that is a very savvy question, and I wish I had a good answer for you. That is still one of the mysteries of the field. There are certain areas of the brain, the spinal cord, that we know MS tends to like more than others. But why, one person will have an attack in one place and another in another place, and why an attack happens at any given time, why it happens today and it didn't happen 3 weeks ago. we don't really know. We think that there are probably, a variety of factors that's involved with that. Probably a lot of them have to do with, with luck. Maybe kind of, your immune system responding to another, virus in the environment or something that gets it revved up at any particular time. We know that, there's some things like, like stress and, some other infections, particularly viral infections that can precipitate an attack. But we don't have a great understanding of all the factors that are at play.
Okay, well, thank you so much, Dr. Kornberg.
Thank you.
I'm going to introduce our second speaker today now, Dr. Michelle Johansen. Dr. Johansen is an assistant professor in the cerebrovascular division of neurology, focusing on how changes in the heart impact neurological outcomes. She will be discussing some of her recent findings, including uncovering the link between what is seen in the heart and in the brain of patients.
Outstanding. Well, thank you guys so much. It's really a privilege to be able to have this opportunity to talk about some of the things that we're passionate about. And it really is truly, like Michael said, where what it is that we really care about is not only taking care of our patients, but also the research that surrounds some of the things that we're interested in. Can I just get a thumbs up that the share is, can you guys see my slides?
Yes.
Okay, all right, perfect. Thank you very much. So I'm going to talk to you guys about something that's a little bit different today. So I know Michael talked about multiple sclerosis, which is a devastating disease, but I want to sort of shift the focus a little bit to the brain-heart axis. And so I want to speak about stroke. Stroke is a word that has familiarity in the community, but unfortunately, a lot of people don't really understand what a stroke is. If you ask someone, for example, to define a myocardial infarction, they can do that. But you ask them specifically what a stroke is, even if it's occurred in their own family, sometimes people struggle with that. So just to set the framework of why stroke is important, it's the second leading cause of death worldwide. It is increasing in the young, and this is something that we're seeing in the United States that's so hard to grapple with, is stroke was forever thought of a disease of 70-year-old men who smoke and drank and ate too much, and that's not the case anymore. Stroke is only the beginning. So for our stroke patients, not only are they dealing with disability and handicap, but they also have poor quality of life. They are at increased risk for depression, loss of income as a result of losing their jobs and being unable to perform the tasks that they normally would. And then finally, cognitive decline and dementia is much higher in patients who have had strokes than the general population. So what is a stroke? So blood traveling to the brain supplies oxygen and nutrients. But a stroke occurs when an artery leading to the brain or within the brain is blocked or damaged. A clot can block an artery, or an artery can burst, reducing or blocking blood flow to an area of the brain. And the area of the brain that's impacted is the deficits that the patients suffer. And I know some of you who are on this are my personal patients, and you recognize so well that if a particular area of the brain is damaged from a stroke, maybe your hand doesn't work. If another area of a brain is damaged from a stroke, maybe you have aphasia or a language problem. It's a very diverse disease that's a result of an embolus or clot blocking off blood flow. So there are three main goals for those of us who take care of stroke patients. The first one is the patient a candidate for acute therapy? And some of you may have been beneficiaries of things like IVTPA or thrombectomy. This is a very exciting field, and it's very important about what we do in those first several hours in taking care of our stroke patients. So please make sure to pass the message along if you develop signs and symptoms of a stroke, to call 911 right away, even during COVID, because there's things that we can do within a short period of time that we can't do elsewhere. The other thing that's important is also to prevent a recurrent stroke. Patients who have had one stroke are at increased risk for having strokes again. An imperative is a diagnostic evaluation to determine the cause of a stroke. If we don't know what caused it the first time, how are we going to be able to prevent it again? And then finally, to prevent complications of stroke. And these are the two areas in which I do my research. So what are the main types of strokes? In order to understand a little bit, normal arteries have intact layers that prevent clots from forming. Your body takes care of clots. It recognizes where the blood should and shouldn't go, and it breaks those down for you using a variety of mechanisms. However, if plaque develops in the artery, or if an embolus or a clot blocks an artery, or the artery bursts, you end up with a stroke, ischemic stroke or hemorrhagic stroke. So the type of stroke dictates treatment. Of course, if the mechanism is different, then the way you treat that patient should be different. There can be disease in the large arteries that feed the brain, either extracranially or outside of the skull, or intracranially inside the skull. Small vessel disease or lacunar strokes. Abnormalities of the blood can lead to stroke. So for example, a coagulation problem or a predisposition to clot. And then finally, venous infarcts. Cardioembolic or cryptogenic or embolic stroke of unknown source is where I'm going to spend the majority of my time talking today. And this is a particular type of stroke that dictates a particular type of treatment. So why study the brain-heart connection? You know, I get questions from patients and people all the time saying, you know, you're a neurologist, why are you so fascinated with the heart? Well, I'll tell you why. It started by taking care of our patients. I remember when I was a medical student and first encountering my first stroke patient and realizing that there was boundaries with regards to what we could do in taking care of our patients. And that continued as a resident, as a fellow, and now as an attending, and recognizing that there are questions that we can't answer and questions that we can't answer. And it's so frustrating for the family, and even probably more so for the family members when they're trying to figure out what to do next for their loved one, and we don't have an answer. And then finally, I've had stroke affect my own family, including my own father. That's quite a story, giving IVTPA in the back of an ambulance to your dad. But this is something that you'll never forget. And this is what drives us in taking care of our patients. So cardioembolic stroke. Cardioembolic stroke, again, is referring to that embolus that arises from the heart and travels to the brain, resulting in stroke. 5-year mortality rate for cardioembolic stroke patients in particular is as high as 80%. That's devastating. That's a lot worse than any other stroke subtype. It has a higher risk of recurrence and more severe physical and cognitive ramifications than other stroke subtypes. So what is the breakdown of stroke? When we think about ischemic stroke, this paper displayed it beautifully, and I thought it might be helpful to understand that about 20% of strokes probably have a clot that came from the heart, but 25% of strokes is in this bucket that we call cryptogenic, which I always like to joke is just a fancy doctor word for we don't really know what caused the stroke. This is quite a preponderance of people then who are affected by clots that either have arisen from the heart or might have arisen from the heart. So this is a pamphlet that was put together by the American Heart Association, for which I do research with, and is a phenomenal institution that's also the American Stroke Association, recognizing that patients who do not know what the cause of their stroke is, how frustrating that can be and how overwhelming that can be. I love this, which sort of encapsulates this idea that there are different strokes for different folks, right? People who have a stroke, it's not all the same. And so if we take a one-size-fits-all approach, we're really doing a disservice to our patients. So the premise of my research is that unless you have atrial fibrillation, which is a very specific heart condition, the treatment for cardioembolic strokes or strokes that look embolic is exactly the same as any other stroke. Sir William Osler, who was one of the founding physicians of Johns Hopkins, said this very poignantly: the greater the ignorance, the greater the dogmatism, right? So we keep doing the same things over and over and over again when we don't really know the answer. So I strongly believe that a new paradigm for embolic stroke is needed. I think that there are patients with evidence of cardiac structure and function that is either considered not normative, in other words, it's not normal, but it's not symptomatic. What does that mean? Or it's symptomatic, but we just don't have any evidence on what to do about it. And guess what? All these patients are treated exactly the same with aspirin. This is sort of a schematic of my research area, which is I strongly believe that there's something called an abnormal atrial substrate that contributes and leads to stroke. All these vascular risk factors, diet, for example, as Michael mentioned, is very important in prevention of stroke. However, all of these things, I believe, act on the heart, and there's an independent path between what's going on in the heart and what's causing stroke in these patients that's independent of just having atrial fibrillation. So how do we evaluate the heart in stroke? Well, currently we use something called transthoracic echocardiography. This is an example of an echo taken from one of my research patients, and I have the left atrium outlined here. It's excellent because it's a routine test, non-invasive, low cost, and we're not radiating the patient. So when using transthoracic echocardiogram in my stroke patients, and this is a publication that came out in Neurology, I was able to demonstrate that there are cardiac structural changes independent of atrial fibrillation that I could see on echo. That's probably on this cardioembolic stroke causal pathway. And that's important for echo, looking at patients and their hearts, and then determining the type of stroke that they've had. I can even take this a step further, and I've included some videos. They say a picture's worth 1,000 words. This is an example of the left atrium beating, which I have outlined here. I can then take it and use something called strain technology to create maps of how the left atrium is beating and moving in space, and then look at strain, which means the stretch on the left atrium. So using this even more advanced echo technology, I'm able to map out the 3 phases of the left atrial cycle that give information about how the blood is moving through the left atrium. So using this information, I was able to show that a larger left atrium and worse left atrial function during certain phases is strongly associated with patients having clots come from the heart and go to the brain. I also showed that cryptogenic stroke patients are a heterogeneous group. This group of patients in which we don't know what caused their stroke may represent a yet undiscovered cardiac cause of stroke. And I think that left atrial functional assessment is the next best step in helping diagnose and give answers to these patients and their families. This led to the DIAC study, and these are the wonderful collaborators here at Hopkins that's helping me run this trial. What we're doing is we're using cardiac CT, and the reason we're doing that is because, once again, it's non-invasive. It gives me even superior information about the left atrium, and I'm happy to take that as questions. But essentially, the way the left atrial appendage is shaped gives you information about predisposition to clot. It lets me look at the arteries that feed the heart, because plaque is different than soft clot and should be treated differently. Here's an example of a cardiac CT from one of my research patients. It's showing contrast in the left atrium, and I can look at the function of the left atrium, as well as showing plaque, this nasty atherosclerotic plaque, for example, in the LAD here of the heart. And those things are not the same, and they should be treated differently when we take care of our stroke patients. Finally, the last area of research that I'm very interested in is cardiac disease and cognition. We know that the #1 cause of dementia is Alzheimer's disease, but a lot of people don't realize the #2 cause of dementia is vascular dementia. And there's an overlap in pathology. And there is evidence that strongly supports that cardiac disease could be a direct cause of brain injury. This is additional work that I do with the Atherosclerotic Risk in Communities Neurocognitive Study. It's in specific sites across the United States. And we've been monitoring patients who are otherwise healthy since 1987. It gives us lots of information using their brain MRI, that echo technology I described, cognitive assessments, and then I took it one step further and used PET imaging. PET imaging allows us to see amyloid plaques, which are strongly associated with Alzheimer's disease. So what did I find? I found that the left ventricle structure of those patients was strongly associated with elevated amyloid plaque, which is associated with cognitive problems. Same with an atrial cardiopathy, or a bad atrial state was associated with amyloid plaques. So while we know that overt cardiac disease is known to result in cognitive impairment, What about subtle changes? Is that enough? I think it might be, and I think tracking cognitive outcomes in our stroke patients is very important. So in conclusion, I think that approach to stroke patients should be like a chain link fence. It knits tightly together, and you can't just take one aspect and then think that's sufficient in describing what's going on in the brains of our patients. It's going to take biomarkers looking at the heart in combination with advanced imaging, which we're using in our research, to define the state of atrial cardiopathy. So then we can treat those patients differently and hopefully improve their outcomes so that mortality and morbidity rates are not so high. So I'd like to conclude. Thank you guys so much for attending, and I would be happy to take any questions.
Thank you, Dr. Johansen. We do have some questions. How much of a role does platelet activation from severe periodontitis play?
Okay, that's a great question. So what happens on with your teeth can certainly affect the brain, and it can affect the heart. So for example, patients who have endocarditis or seeding of the heart valves, those things can break off and go to the brain too. And we know that poor oral hygiene is associated with increased risk of infection, including seeding the heart valves. So that can absolutely result in stroke. It's amazing how clots and the way that clots are formed can inform so much of the way that we think about where clots come from. And I think that's a very insightful question, because embolus is just a medical word that means clot that came from somewhere, right? And we have to figure out where the clot came from, so that way we can prevent stroke from happening again.
Okay, next question. Should a child not be operated preventatively if they have PFO under any circumstances?
Okay, so that's a great question too. So a PFO is a patent foraminovalee, and that's one of the heart conditions that I didn't specifically mention. But a PFO is a hole in the heart. So children have PFOs naturally, and then they get to a certain age, the heart closes up because they don't need that circulatory support from their mom anymore, and then they direct blood other places. There are lots of people walking around who still retain that very small hole in the heart. But sometimes in specific cases, it can be a cause of a stroke if a clot has traveled from the leg, for example, through that hole in the heart to the brain. But the evidence thus far is for patients who have cryptogenic stroke, right? Which means we don't know the cause, which is why it's really important you go to a stroke neurologist who does everything necessary to make sure that they rule out everything else. And then if you meet certain criteria, absolutely, that PFO should be closed. But that evidence is in adults. The mechanisms for strokes in kiddos is different than the mechanisms of strokes in adults.
Is there any new data on HRT and stroke? HRT seems to be making a comeback.
Yeah, very insightful question. So the best data that we have with regards to HRT, in case others don't know, that's hormone replacement therapy, and that's given to women. I do see a high degree of women in my practice, and even younger women now. So that, once again, that age demographic is shifting more and more. Hormone replacement therapy, that is correct. It is, in fact, trying to make a comeback. But the best data that we have is from probably about 10 years ago or so, that showed that hormone replacement therapy can increase a lady's risk of forming clots. And the estrogen progesterone system, I could talk about that for hours, but estrogen is associated with clotting. And so as a result of that, the thought is that if you take estrogen or too much estrogen, you may be predisposing yourself to risk of stroke. And the good news is that medicines to sort of modulate the symptoms of menopause are better now than they were when we were using hormone replacement therapy. So still, as a vascular neurologist, I shy my patients away from hormone replacement therapy, especially if they have additional risk factors like diabetes or high blood pressure or obesity.
Is there any evidence for fungal basis for stroke?
So that once again refers sort of to that pericarditis question, or poor dental hygiene, etc. So you can get stroke in the setting of infection, right? So for example, in the news, there's a lot of fascination about COVID-19. Can patients be at increased risk if they have COVID-19? Any sort of infected state can increase your risk for forming clots. But a fungal particular disease is pretty rare to be associated with stroke. But that's not to say that it's not associated with stroke. anytime you're infected, your body, it's a pro-thrombotic state. So your body likes to form clot in the setting of severe infection.
Okay, and one last question. Are you aware of the use of acupuncture for stroke patients?
Sure, yeah. So I see that there's, I'll take that and then Plavix quickly. So acupuncture, so I always tease with my patients that as a traditional MD, I have lots of people in my family who believe in alternative medicine. So there is no evidence for harm with acupuncture. The evidence for benefit with acupuncture, there's some to suggest some. So if you find acupuncture to be helpful, especially for stroke recovery, then by all means, that if there's something that you can find that's helpful for you, that there's no evidence that suggests it's harmful, then I tend to support that in patients who are just struggling and trying to recover from their strokes. And then that Plavix question, that is a complicated one. We do use Plavix, definitely, instead of aspirin in particular situations and particular stroke subtypes. But once again, that just goes home to that message that you need to know the cause of the stroke in order to be able to treat the patient. And it's so frustrating for patients when doctors sort of throw medicines out there. But the real important point is to find out what causes stroke so you can prevent it again.
Thank you so much, Dr. Johansen.
Thank you, guys.
Our last speaker this afternoon is Dr. Ankur Butala. Dr. Butala is a movement disorders neurologist and neuropsychiatrist, holding appointments in the departments of neurology, psychiatry, and behavioral sciences. He has expertise in managing Parkinsonian disorders, ataxias, and other neuropsychiatric conditions. His most recent work focuses on developing functional circuit models of cognition and mood with non-invasive biosignals.
So, hello, everyone. Again, I echo what Michelle and Michael said. So thank you for inviting me to this conference. Can everyone hear me okay? Can I get a thumbs up there? Okay, great. So I'm going to get started on a brief overview of sort of my background as a clinician scientist, and we'll talk a little bit about Parkinson's disease. So, okay. So my background is I'm a neuropsychiatrist. And so neuropsychiatry is the field of medicine that studies disorders that have a myriad of manifestations across the mind, brain, and body. And I'm also a clinician scientist. And so my primary goal is to optimize care in treatment resistant or treatment refractory conditions, regardless of the specific disease, but just addressing the commonalities. And one of the things that I've come to appreciate is that in science, we often have forgotten things that we had already discovered in the past, but just didn't know quite how it worked. And this is particularly relevant for movement disorders and neuropsychiatry because back in the 1800s, the two fields were unified. And it was only after the early 1900s, essentially when psychological theories and Freud and whatnot gained dominance, that the fields sort of split. But as I was training, it just seemed to make sense. It seemed that the distinction between what is brain and what is mind or what is neurology and psychiatry were somewhat arbitrary. And it's perhaps most evident in looking at the circuits that connect both movement, how you feel about things, or association, and limbic cortices. They all have this pattern of connection that goes from cortex down to the basal ganglia, the deeper structures of the brain, down to the thalamus, and then sort of back. And this same circuitry is at play, sort of regardless of a specific disease in many instances, which I'll sort of touch upon in a moment. It kind of reflects what one of my mentors told me, is that emotion and motion are sides of the same coin. And so by extension, I actually pursued a fellowship here in movement disorders neurology to basically approach as a kind of language to approach cognitive, mood, and behavioral disorders. So with that in mind, I'll talk about the most common disorder that I see, which is Parkinson's disease. So Parkinson's is the most common adult onset movement disorder. We estimate about 60,000 people each year are diagnosed with Parkinson's disease. As of today, I would estimate there's perhaps a little bit less than 1 million people in the United States with Parkinson's. And probably within the next 10 years, by 2030, there might be a little bit short of 1.5 million people. And as of today, we have no cure for Parkinson's disease. And barring what Michelle might opine, the biggest issue is that time is brain. And as you can see in this illustration here, is the disease often starts many years, if not decades, prior to the onset, prior to when someone actually walks in and sees a neurologist. And so what is Parkinson's disease? Well, Parkinson's is the loss of the ability to make this little molecule here that's called dopamine. And the progressive loss of dopamine causes a myriad of physical and cognitive and mood symptoms. So the literature from pathology would argue that we have already lost something like 50 to 80% of the cells that make dopamine by the time a patient walks in to see a neurologist. And if you look at the illustration on the right, there's a spectrum of very early symptoms that someone might have that are extremely subjective. Things like acting out dreams, mood changes, constipation, and so on. And the biggest issue in terms of a cure for Parkinson's, as I said, we don't have one as yet, is that these symptoms smolder for a long period of time, so the momentum builds. And so by the time you see someone, you're already kind of behind the 8 ball. And so when we talk about curative techniques, not only do we need something that stops it from getting worse, but you need something that reverses damage that's already done. And that sort of frames why research into stem cells and these kinds of things haven't really panned out quite yet. Because even though we can put them there or get your cells to make dopamine, we can't sort of reconnect them to everywhere they need to be in the brain that took basically your entire life. And getting back to the diagnostic piece is that a lot of these symptoms here are extremely vague. They're highly subjective, and that leads to room for interpretation, which leads me to my second point, which is that for me to say someone has Parkinsonism is pretty straightforward. All it requires is I have someone do this or this, and through repetitive iterations, it gets smaller or more effortful. Maybe they have some stiffness on one side and a little bit of tremor. That's basically it. So neurologists will joke it takes about 2 minutes to figure out if someone has Parkinsonism. But the point is that is it actually Parkinson's disease or is it one of a number of associated symptoms? So most of the time, 60 or 70% of the time, I see someone with a combination of slow movement or tremor or stiffness. It's what you might, Parkinson's disease, what you might read about. But the other percentage of the time, these are either cousin disorders related to Parkinson's or mimicking conditions of Parkinson's disease, so-called secondary Parkinsonian conditions. And to further highlight the difficulty here, the scope of the problem, I'm going to highlight the atypical Parkinsonian conditions, in particular, two of them, progressive supranuclear palsy and corticobasal syndrome. So this, not to overwhelm anyone, but this next slide here is an illustration of the different kinds of symptoms we might see in some of these atypical Parkinsonian conditions. The PSPs, the corticobasal syndromes, are a subset of a larger family of disorders called tau disorders, which are generally classified as frontotemporal lobar degeneration. And I illustrate this because there's way too many other symptoms that people can have. Everything from movement symptoms, jerking movements, mindfulness to cognitive symptoms, loss of apathy, loss of emotional engagement and apathy, to postural symptoms, to change in how people eat or drink. There's too much noise. And even though some things seem to cluster together, um, this reflects the when you're a hammer issue, which is when a subspecialist sees someone, they generally interpret the presentation, the symptoms in context of what their specialty is, not exactly what's going on. And so that is what we might call a phenotype. And so this leads me to a fairly recent collaboration I've started with the School of Engineering, is can we use machine learning and artificial intelligence techniques to create a deeper phenotype, to basically better explain what we see from behavioral data, from performance in various tasks, to create a better computational model of why we see certain problems in certain diseases. Because the issue being when patients don't read the textbook, and they often come with various complaints that don't quite bin neatly into a specific disorder. And sometimes as a clinician, you're not able to efficiently recognize or bin all the symptoms together to discover the underlying condition. And that's why we often say time will clarify the issue. But this, as I said, puts you behind the eight ball, and this could lead to some unnecessary delays. And so I want to just illustrate what I mean by how we create deeper phenotypes by using both two of the tasks that we've developed. So these are a collection of eyes. And as you could see, that when a visual stimuli occurs and you don't have any issues like Parkinson's or an atypical disorder, you move fairly quickly from your midline position to the target. But when someone has Parkinson's, as you might be able to detect, there's a slight lag. And over time, they're not able to get to target as appropriately. This is even more clear with PSP, in which how fast the eyes move is actually a core aspect of the condition. And then I'll illustrate a second version of this, which is up and down, which really shows the difference between Parkinson's disease and one of our atypical disorders. As you can see here, gradually a little bit of a delay. And this delay actually will improve with someone takes a medication for Parkinson's, levodopa, or in the situation in which they have a deep brain stimulation lead implanted to reverse some of the Parkinsonian symptoms with no substantive movement in the PSP cohort. Now, I'll also point out that eye movements, and this is just one example of the kinds of tasks that we're having participants use, are incomplete. They don't provide as clear of a picture, and things can be lost in when we're analyzing these patients. So we decided to add a second task, and I'd like you to hear it.
My life is relatively quiet, and I'm actually having a really good time. People never believe me, but I love life.
As you can hear, his voice is soft.
I have things I have to deal with, but I have things
it's a little slurred
that are just incredible. My family.
There are a few hesitations in how he's speaking.
That I've been doing something I love to do, and so it's the last couple of years have been trickier than most, and I'm grateful that I went through a crucible there at this late stage in my life, relatively late stage, my late 50s, that I figured some of this crap out finally.
And then in contrast, we have some of the cousin disorders.
I'm James Bork, MD, and I have a prime disease called MSA, multiple system atrophy.
And Dr. Walker is actually a pediatric neurologist, and you can see how breathless and whispery his voice was without any of the hesitations that we had heard previously.
My name is Pierre Gervain. I've been diagnosed with PSP in the prime of my life. What it means is that I've got some difficult issues to handle, and I'm working through them. PSP is progressive supranuclear palsy.
And so Mr. Gervais, you could tell that his voice sounded somewhat faster than the prior two. There's a bit of nasality to it, and he had some hesitations. And interestingly, as a clinician, I can tell you that his voice doesn't sound entirely typical of someone with PSP, just for reasons I can't quite clearly articulate. But he had unfortunately passed away, and when they actually looked at his brain afterwards, discovered a different disorder, corticobasal syndrome. So it highlights that even the uncertainty is still present, and only when someone's passed away do we get a really clarity on what was going on.
Well, I think that's true in some context. I mean, it gets so locked in and so right, and it troubles me a little bit. But overall, I don't feel that way. I don't think we ever proposed. We never said, will you marry me? I mean, it's never dramatic like that. It's kind of wedged into it there.
And you can see, aside from President Bush's drawl, that there's a bit of slurring, there's a few more hesitations. And so it's clear that by just listening to how certain folks talk, there are acoustic signatures that are different between and among these disorders. So this brings us to our primary collaboration is that we are in process of recording non-invasively a combination of eye movement and speech in various tasks, such as looking at something, looking at different figures, exploring a novel stimuli, and so on, in both persons with Parkinson's disease and controls, and then essentially teaching an AI to find and extract the most relevant signals embedded within there. So is everything from the most obvious, which would be, is there a lag time between when a visual stimuli appears and someone looks at it, to something like, is it the hesitations in their voice? Is that analogous? Or the quality of how their vowel sounds to distinguish these conditions. And this is really only the first step, in that we would later, having taught the artificial intelligence this the ability to do so, would compare across a variety of other disorders, mimicking conditions of Parkinson's disease, such as major depression, cognitive impairment, associated atypical Parkinsonian conditions, or other mimics, other gait disorders like ataxia, to sort of be more informed in how we diagnose these different conditions. So the overall goal basically is that we want to increase our precision with how we come to diagnoses. We want to reduce some of the subjectivity that's inherent in what I kind of mapped out before, because the increased objectivity will increase precision, and then we'll be better positioned for treatment options. The other issue is that, sorry, one moment. Okay. The other issue is that it's well and good if that you're seeing a subspecialist at an internationally recognized academic medical center, but there are often delays with getting to see that subspecialist level care. And by creating a system that permits the recognition of these harder disorders early, we can appropriately triage patients to a subspecialist level care and thereby increase accessibility. And ultimately, we want to create better models to approach these disorders generally, because the biggest problem that we have in the care of Parkinson's disease and associated conditions is we don't have a good model that encapsulates all the myriad aspects of disease. And this makes it exceedingly difficult to provide treatment, because it's sort of a black box. You don't know what's going on underneath. And so with that, I want to thank everyone for being patient and listening and bearing with me given the interruptions that I was having. Any questions so far?
We do have some questions for you. Thank you so much, Dr. Butala. Is it true that unlike the new antipsychotics, the old ones such as, and forgive my pronunciation, thiothyxine and trifluoperazine, my sister's a pharmacist and she would murder me, have not been associated with the development of metabolic syndrome or diabetes?
Yes, that's true. That in general, the older generation antipsychotics do not cause as much metabolic issues such as weight gain or perturb euglycemia, glucose metabolism, as do the older ones. And so there is something in favor of them. However, the trade-off is the older generation is more likely to cause drug-induced Parkinsonism and other movement disorders.
Okay, how effective is medicine for hallucinations in Parkinson's patients?
That's an interesting question. It kind of depends upon how bad the hallucinations are and how they're bothering you. The short version is it doesn't matter to me so much if my patients have hallucinations, if they can tell that they are not real. I've had many patients tell me that they see, quote, well-dressed hobos wandering around their house, and they don't really bother them or distress them at all. However, if they reach a point of severity where you can no longer tell they're not real or they are frightening you, that's a clear indication to start treatment. Now, it is true that we have certain effective medications. The difficulty is balancing the treatment of Parkinson's without affecting the movement symptoms, and that can be a difficult balancing act.
Are you trying to incorporate visual recognition technology?
So I'm not sure what you might mean by visual recognition technology. Um, we are we are planning to implement motion capture technology. So these would be some combination of that you might see used in Hollywood for gait analysis and some of the other difficult characteristics that we can't quite fully capture purely with eye movements or speech characteristics. But I don't know if that answers your question directly.
And the last question, are there swallowing difficulties in people with disorders like Parkinson's disease or other Parkinsonian disorders?
Yes, that's absolutely true. That Parkinson's disease and associated conditions, among the main issues that cause long-term disability, is difficulty swallowing and complications that arise from aspiration pneumonia. So that's an exceedingly important symptom that definitely should be addressed.
Great. Well, thank you so much, Dr. Butala, and to all of our speakers. I'm going to send it back over to Jamie to close out our program today.
Hi, everyone. Can you hear me and see me?
Yes.
Great. Thank you so much. This has been so much fun and so interesting. We'd like to thank all of you for your time and your talent. And we'd also like to thank our guests for joining us for today's webinar. A follow-up email will be shared with you following this webinar that will include a recording of the program along with a list of resources and our event schedule. We hope you'll join us at a future webinar. Thank you so much. Have a nice day and be safe.